Good morning, Chairman, ladies and gentlemen. Thank you for giving me the opportunity to present the outcomes of cryoablation on paroxysmal, persistent, and permanent atrial fibrillation and concomitant cardiac surgery. My name is Aktuerk. I'm a trainee on the West Midlands rotation. There are no disclosures. Atrial fibrillation remains the most sustained cardiac arrhythmia and can lead to palpitation, hemodynamic instability, thromboembolism, and stroke. The MACE procedure, first introduced by James Cox as a cut-and-sew technique, remains the gold standard with a high efficiency and high success rate. However, it is quite complex and time-consuming. This has been supported by recent data published by the STS that only 38% of US surgeons perform a surgical ablation. Our study population was divided into 3 groups. The first group, according to guidelines, paroxysmal AF group with a recurrent episode of AF that terminates spontaneously, persistent AF group with a sustained episode longer than 7 days or necessitating cardioversion, and our third group is the permanent AF group with a continuous episode over 1 year and in which no further treatment of any kind is considered. The aim of our study was to demonstrate the outcome of the modified Cox-Maze-4 procedure with cryotherapy in patients with a history of atrial fibrillation undergoing concomitant mitral valve surgery. This is a single-center study with a single ablation pattern adopted in all patients since 2002, with a single energy source, cryoablation, and performed by a single surgeon. All patients receive an ECG at discharge, 2-month and 12-month, and all patients receive a 24-hour Holter tape before discharge. The device we are using is one of the earlier devices, which is based on nitrous oxide. It cools the tissue to minus 60 degrees, has a reusable probe, which is solid, and after frost completion, we hold for 2 minutes. We perform 5 left-sided atrial lesions, a right isthmus lesion in the form of a cavo tricuspid lesion, and in all patients, the left atrial appendage is excluded. After a standard left arteriotomy, we extend the incision around the inferior right pulmonary vein towards the left inferior pulmonary vein and perform a right pulmonary vein isolation. We then go on to perform a left pulmonary vein isolation. Our third lesion is an inferior pulmonary vein interconnecting lesion, and we then go on to perform a left atrial isthmus lesion, here seen in number 4, to the mitral valve annulus. The last lesion is a left auricle isolation lesion, to be seen here, which then is completed with an interconnecting lesion to the superior left pulmonary vein. We also perform a right isthmus lesion, which is a linear ablation line from the IVC to the coronary sinus and from the coronary sinus to the tricuspid annulus. All patients receive 150 milligram of amiodarone on pump. We continue with the amiodarone unless contraindicated. All patients are paced for at least 24 hours, and we adjust the pacing according to the rhythm status after. We performed this procedure on 369 patients from 2002 till August 2012. We identified 173 patients with paroxysmal AF, 36 patients with persistent AF, and 160 patients with permanent AF. We found that there were no complications related to the use of cryoenergy. However, we observed that an increasing number of patients require rhythm monitoring. The in-hospital mortality was 4.6%, stroke rate 2.4%, and 5.9% of the patients required a permanent pacemaker. 90% of patients with a history of atrial fibrillation and undergoing mitral valve surgery received AF ablation. We found that in our paroxysmal group, 78% of the patients were on discharge in sinus rhythm. This decreased over 1 year to 77%. In our persistent group, we have 50% on discharge which then decreased to 47% over 1 year. In the permanent AF group, well, 56% of patients are in sinus rhythm post-op. This decreased to 51% over 1 year. All patients receive a 24-hour tape on discharge. However, we don't have long-term monitoring right now available for the follow-up patients. Compared to, for example, bipolar radiofrequency ablation, we do not perform an intraoperative lesion monitoring. All patients underwent mitral valve surgery, and the results in combination with a surgical ablation for atrial fibrillation are in the literature variable. Our follow-up period is relatively short, so we can't really comment on the long-term efficiency or the recurrence rate of AF. Our follow-up is, up to this point, not complete. But what we can conclude is that after 1 year, at the short-term, cryoablation is a safe and efficacious treatment of all types of atrial fibrillation. Especially, we have a positive outcome in the persistent and permanent group. Due to the reusable probe, the procedure is cost-effective. What we are going to do is we are trying to complete this study now with introducing long-term monitoring for this patient and a transthoracic echocardiogram, and we continue to collect the data on these patients. Thank you very much.